Okay, so our next speaker is Dr. Tom Robinson, who's professor of surgery and has really ably served as chief of the VA for many years and has been really a great partner. He did his undergraduate training at Stanford, medical degree at Columbia, general surgery training at the University of Colorado, and then an MIS fellowship at UCSF. He's also completed a master's in science here at CU. He's well published, as I stated before, an excellent leader. And just to give one example is our Center for Surgical Innovation, which is really nationally and even internationally recognized, with people coming from everywhere to receive very specialized training at our center. And, Tom has managed it so well. I'm the chair of the board. I really have not had to problem solve that much because Tom usually comes to me with, okay, here's a major issue. Here are the 3 potential solutions. And I think we should go this way. And he's always right. He's a great surgeon and physician and a leader in geriatric surgical care, which you'll hear about this morning, and has received grant funding for this and has written many, many papers. Tom, thank you very much.
Thank you, Dr. Schulich and Dr. McIntyre, for the opportunity. I really do appreciate it. I was going to be on the move, but I guess this is a little bit on the fritz, so I'll stay behind the microphone. So how many here woke up this week and were like, I'm glad finally geriatric surgery grand rounds? Who said that when they woke up? Hey, all right, just if it's not true, don't tell me, lie to me. How many people, so a lot of people don't raise their hand. A lot of people are smiling and raising their hand. How many people here in the last 30 days have had a patient 80 years or older on their service, stayed longer than they should have, couldn't discharge them for some reason, and in general created a lot of phone calls to the resident team? Right, and everybody raises their hand on that. So this is a topic that we're not all sort of enthusiastic about, I would say. But this is a topic that affects us every single day. And so why does that patient stay a long time? I want you to start thinking about that. I have a couple slides on why that is. And we're just going to conceptualize this. And this talk is more on processes than outcomes, because we're going to go over how we can develop a quality program to manage those patients. But if you want to talk outcomes, we can talk outcomes too. So here's what's going on. You as the surgical team, and I'm really going to drive this at the residents, right? You're focused on the primary disease process. You have Dr. Schulich's team is doing the major hepatobiliary work. So they're focused in the middle of this circle. They're focused on that biologic disease process. Or you're doing a segmental colectomy. So you're going around and you're saying, are your bowels working? You're looking at the wound, right? You're mobilizing the patient. So you're very disease focused. And I think for somebody my age, sort of a 50-plus-year-old person, that's fine. But for the 80-year-old, yeah, you need to be doing that. But what's actually happening to them is they're developing geriatric syndromes. And those are the wheel on the outside. And this whole talk is going to be focused on that outside wheel, that your vulnerable 80-year-old older adult, that's what's happening to them while you're focused on that primary disease process. And this is why they're staying a long time. So what's on that wheel? Delirium, functional decline. So that's keeping them in the hospital. Impaired mobility. So mobility and function are different. All right, they're getting deconditioned very rapidly, whereas your 50-year-old won't. Pressure ulcers, which are really linked to hypoactive delirium, and poor nutrition. So all of these things are kind of holding them in the hospital. I'm going to start with the why we want to do this program, and then we'll go over the program. So there's only 2 studies that have looked at geriatric surgery programs. The first one is out of on our campus here at the Rocky Mountain VA. And we looked at, so we were one of the early adopters of the American College of Surgeons has a geriatric surgery verification program. We adopted it in 2018. And so this is data from kind of 2019 to 2020, 21 or so patients. And so what we do is we take everybody 75 years and older, and then we focus deliberately on those geriatric syndromes: function, cognition, nutrition, right? And what outcomes can we expect? Well, we can reduce their length of stay. And so we reduced the median length of stay by a day and the average length of stay by more than that, but it's probably more accurate to look at the median. And so we can reduce the length of stay. So the first thing I'm going to throw out to you as the residents is if you want to reduce the length of stay of the patients on your service, we should think about implementing a quality program for older adults. The only other manuscript is Susan Gerhardt's group out of Bayview, which is in Baltimore. She did the same thing, except when they published this, they used 65 and older, and they took only patients who were frail, which we'll get into that just a little bit, but they had vulnerability characteristics that some older adults have. And they showed that you can reduce the length of stay. So I think it's going to be pretty durable that if you have a geriatric surgery quality program, you can reduce the length of stay for the patients included in that program. And that's been shown very well in medical hospitalized patients, but these are the first two studies that are really getting in there for the surgical hospitalized patient. The other thing that Susan's group showed was that you can preserve function. So preserving function means you can protect somebody from being able to perform their activities of daily living at the time of discharge. Okay, so here we go. We're going to embark on this program. We're going to try to reduce the length of stay for our patients. So what are we going to focus on? Well, we're going to focus on that wheel that's outside this geriatric syndrome wheel. I want to introduce you to two concepts that Medicare is very interested in. This is the first of the two concepts. You should probably know this jargon of what the 4 M's is. And has anybody heard what the 4 M's are? All right. So if you go into, it used to be when you went into Medicare, you would see on the wall when you got in, it was all about function. But right now they've shifted to the 4 M's. So we should know this. And these are what the geriatric surgery program is going to be focused on. So what matters is the first M. So that's goals of care. And if you think about it, you're bringing somebody to the operating room for an elective operation, you can actually address their goals of care in a meaningful way before you go to the operating room. I'm going to go around the wheel to the right. Next one is medications. We can make better and worse medication choices, right? We can promote delirium. We can promote functional decline based on the medications we choose. And I'm going to go over, I have one slide that's on the Beers medications. That's the second geriatric concept I think you should get, but the 4 M's is the first one. We're on the bottom of the wheel, which is the mind. That's delirium. So acute brain dysfunction after the operation. Going up on the left side is mobility. So they include mobility and function as the same thing, but preserving the patient's ability to walk around and function after the operation is the fourth one. So the American Geriatric Society has a fifth one, multi-complexity or multi-morbidity. Probably know that one, but this is the one that CMS is honed in on. Probably file that one away, the 4 M's. You're going to be seeing that coming up in the future. So we're going to assemble our team. And maybe you don't know, but like when you have an American College of Surgeons quality program, you have to assemble a team. Like for your trauma center, you need interventional radiology, you need vascular surgery, you need a blood bank. Well, you need a team to do a geriatric surgery quality program. Here is our team. This is the team that's outlined in the standards. Your team can vary based on the champions at the hospital. I'm not necessarily going to read through these various folks, but you have the surgical team. You certainly have decision-making folks for what matters, like palliative care. You have geriatric expertise and all the subspecialties to be involved with that patient's care along the way. So we assemble our team and then we launch the program. So you don't have to read all this. I'm just going to go over the processes and the nuts and bolts about what you could implement at your hospital to improve the care of older adults and ultimately reduce the length of stay. So I'm going to show a picture of the patients. And I want you just to think in your head about which patient you think is going to do the best after surgery and which patient you think is going to do the worst after surgery. So you look at those. Is the patient on the far left going to do the best? How about the far right? Now, a lot of folks would say, gosh, that gentleman on the far right side of the slide deck isn't going to do very well. And so the visual cues that you're picking up on are, number one, the patient needs help transferring out of bed. So that's an activity of daily living. Look at the patient's legs are pinned together. So if that patient was to stand up, nobody in this room stood up today like that. That patient's going to fall when they stand up, right? That's actually geriatric syndrome. There's a walker in the room. right? So they have impaired mobility. They have to use a walker. So you're picking up all these visual cues. And actually, one of the things that the old Denver VA was known for, we were the first group to kind of put a score on that patient for surgeons. So we actually were able to count up, and we said, if you have a score of 3, you can do worse than if you have a score 1. So we quantified the vulnerable or the frail older adult. But you can see that qualitatively. And this program is really targeted for that gentleman on the far right, right? That's the person. So the residents think of like having a trauma activation when somebody comes in with unstable vital signs, right? We mobilize these resources. We go down to the bedside. That patient on the far right, while it's kind of a silly analogy, for geriatric surgery, that's your activation. That's the patient that's going to have a really long length of stay, going to get parked in a nursing home afterwards, right? So you're going to take away from their independence and their quality of life. So that's the one that we're going to have to focus on. All right, so here we go. So what you do, you just check the box. And then the geriatric surgery team, we call it the aging surgical wellness team, takes over. Similar, because all the interns, when they hear, oh my gosh, we're going to do a quality program on older adults, it's going to be me. It's not going to be you, right? And if you come over to the VA, it's really not the resident team that does any of this stuff. It's a team that works in the hospital. When you consult respiratory therapy, right, you need to be knowledgeable enough to say, oh, I need to consult respiratory therapy when I have like an upper midline incision, thoracic incision, when somebody has severe COPD. But the respiratory therapist comes in and does all that work. So you need to be clever enough to say, oh, this is an older adult. And the cutoff here is 75 and older getting an inpatient operation. I'm going to check that box. And a bit like respiratory therapy is going to come to the bedside, the aging surgical wellness team is going to, all of a sudden, you're going to activate that team. And we're going to go over what that team kind of does at a high level here. So there's nothing. So the interns, if you're like, oh no, here it comes, intern's going to go do it. You're not. Here comes the team. So the first thing we do is we quantify the vulnerabilities. We used to do this by having the patient do it in the waiting room. We'd have a checkbox. Then we actually did a frail assessment, like it's morphed over the years. Now we've converted all to phone calls because we have a lot of folks that are in Wyoming and Montana. I'd imagine you have a lot of folks that are traveling a long distance. You can't have the patient coming in for each one of these appointments, right? So we've converted to this. We have an RN call them, and it's a checklist-driven vulnerability score. And what we're looking for is we're trying to quantify that person you saw on the far right that was pretty obvious when you kind of looked at them. Well, we asked them and their caregiver questions. Hey, about function, about cognition. We have a validated cognitive tool about how their mobility is, whether they fall. So, right, we have this sort of array of questions that is done purely over the phone. And then once we ask those questions, so we try to do it that right when the team does an intake, our RN is on the phone either that day or the next day calling this person because we want as much lead time before the operation because we're going to start getting that patient ready for the operation the day we know they need to go to the operating room, right? We're not waiting for the day before. And because, right, so we've heard prehabilitation and multiple. So here's what we're up to is we actually, every single characteristic that has what I would call as a deficit or an abnormality. So, right, if that patient has impaired function, occupational therapy, if they're a long distance, we've got to do it on the phone. If they're a short distance, we have GeroFit. They can actually come in and we have a facility to do this. If they're falling at home, right, we have a gait and balance physical therapy clinic. And again, we'll be doing that virtually. We can either do it by video conference or by phone, ideally in person. But again, a lot of our more complicated patients are coming from a long distance. But we're going down this checklist. And actually, we've made it that the note that the nurse does, so you click the note, the patient doesn't have an advanced directive, up pops the advanced care planner, and they get consulted right away. So that kind of so it's sort of this automatic checklist. So we are measuring the deficits by phone, and we are starting to optimize them right there. I'm not standing up here saying that is going to change their outcome, but I am standing up here saying that, listen, if you start physical therapy before the operation, set their expectations about what physical therapy is going to be after the operation, right? And then we actually do it after they go home. And so it's like running this long race. We start beforehand, do it in the hospital, and do it after discharge. And, so it's sort of this full court press. Once we measure these, they go to a multidisciplinary clinic team sort of meeting. So we have a committee meeting once a week. All those team members that you saw on that first team member slide, they get on this meeting. Our only problem with this meeting, when we started this meeting, nobody wanted to go. Our only problem with this meeting now, everybody wants to be on this meeting. And you're saying, oh my gosh, you're going to make me go to a meeting? Who here has gone to a tumor board in the last month? Right, we got a lot of people. So we have multiple. Who here has gone to a transplant? If you're going to allocate a resource, take complex care of a patient. Taking care of older adults consumes the most hospital days of any group. You have 15 minutes for a high-risk multidisciplinary committee meeting. If we have a robust 75-year or older person, we just flip over them, right? So if you are normal on all your frail characteristics or those vulnerability characteristics, we don't need to focus on you. We don't need to focus on that gentleman on the right. We need to focus on the person on the far left. When we hit that person, the whole team slows down and everybody, this is like your activation. Everybody's going to be mobilized at. I'm not going to point out who's on this call, but we have more than all those disciplines. And you can see that bar on the side. There's a whole bunch of people down below that you can't see. This call, when somebody's truly vulnerable of having an adverse outcome, we actually include the family and the caregivers on the call. So you can see Teresa leads this, and we review the patient for 5 minutes for the whole group. The group has the patient's name to pre-review. We review them for 5 minutes on the phone, and actually the patient and caregiver get on the phone, and we kind of talk through, look, this is what's going on, and try to manage their expectations so they understand truly what's going to happen around surgery. All right, we're going to shift gears to after surgery, right? So we set them up, go to the operating room. If you're that gentleman on the far right, that guy that we need to put all the resources in, so they're being optimized beforehand, we schedule them first case in the morning, and then the aging surgical wellness team sees them that afternoon, right? It's this full court press, and then we're going to see them every single day during their hospitalization. It's checklist-driven medicine, so an RN is rounding. If there's problems, right, if there's a medication problem, they just talk to the pharmacist. But if there's like clinical problems they want to like write orders on, they come and talk to us as the physician leads, and we kind of manage those proactively. The vast majority of patients just roll right through, right? A total joint that's 77 years old, that's robust, we'll never kind of hear about, and that the aging surgical wellness team will see them, but we're not intervening on. But you do a major operation on a gentleman on the far right, this team is enormously active in the care of the patient for that outer wheel, function, cognition, nutrition, all that kind of stuff. All right, so there's the buckets, the 4 categories that we disproportionately look at. Who knows what the most common complication in older adults is after an operation? Been written is in the New England Journal of Medicine in '88 was the first time that I've ever found it written. You should think about that. Hands down, it's delirium. And this was just, we did in 2013, designed about 16 variables, had 26 hospitals collect them. Ronnie and I designed these variables. We did it through the NISWIP collaborative. Delirium accounted for as many complications as like 6 or 7 of the other complications that are, right? This is enormously common in your vulnerable older adult. So I'm going to have like 6 slides here on delirium and then 1 or 2 concluding, and we'll end right on time. So I want to highlight what this is my last outcome slide. You can see it's mostly processes here, but I want to highlight because I see Allie over there, Heather Carmichael. It's always good to highlight what our residents are up to. So this is one of the nice papers that our residents published. So everybody up here knows it's textbook knowledge that delirium is related to increased major complications, longer hospital stays, readmissions, need to go to nursing home, right? That's sort of this cookie cutter, what's in the textbook. But what Allie and Heather and all of them said, well, is delirium related to more of these patient-centered outcomes like walking? And so in the red, so these are patients 75 years and older. Actually, that's not true. These are patients 60 years and older having major inpatient operations. And then what we do is we actually put one of these accelerometers. Who tracks their steps? So, right, we track your steps. And so we track their steps before surgery. And so on the y-axis is the percent of baseline. So we want folks to get back to 100%. You see nobody here. At the most, somebody's getting back to 60%. We have delirium group is yes, which is in the red, and you have the 95% confidence interval. And then you have the no delirium group up above. You can see how many fewer steps patients regain if they have delirium. To give you just a sort of more practical view on this, our average patient pre-op is walking about 6,300, 6,400 steps. So at a third of their steps, they're walking about 2,100 steps 30 days after their operation. If you look at your watch right now and see, I'll look at my watch, my dog and I went running, so I have 6,500 already, right? And I'll bet you there's nobody in this room that has less than 2,100 steps, and it's what, 7:15 in the morning or something like that. So 2,100, this person's not mobile. I see Rich is looking at his steps. What are we doing, Rich? Now you're not telling us? Yeah, all right. But I think that, right, so 2,100 steps, these people are not walking at 30 days. And this is a big impact to their life. So we want to prevent delirium. 30% of delirium we can prevent if we just have a simple bedside nursing protocol in place. All right, here we go. So I'm not going to go over, it's the HELP program, the Hospital Elder Life program. There was a 1999 article in the New England Journal that went over it. But what we're doing is we're intervening with simple bedside items like that are listed on the left here. So we're orienting people to person, time, and place 3 times a day. We're walking people in the hallway 3 times a day. We're letting people sleep at night, keeping them awake through, right? Managing their sleep-wake cycle. We're choosing medications that we're going to look for in a second here. We're choosing medications that don't promote delirium. We have opioid-sparing analgesias, right? So we treat pain initially with ice packs, with regional blocks. We don't pull out the oxycodone as the first one. We should use oxycodone in narcotics, but that should be our last thing. I've shown the one that we developed. It took us 8 months to develop that because you have to get nursing buy-in. This is almost one that's got to come from the nursing team to the surgeon team, not vice versa. But 30% of delirium, you can prevent that. I put this up mostly for the interns. You know, there's reversible cause of delirium. We don't want to be getting called on delirium and it be hypoxia and we're not managing hypoxia, or hypoglycemia and we're not, right? So we have to know, or an electrolyte abnormality, right? So we actually, as a surgical team, particularly the first line call folks, there are reversible causes that we don't want to be certainly managing with Haldol or something, right? Somebody who's hypoxic. So you got to actually go to the bedside and make sure that everything's on the up and up. I listed on the right side. The left side is kind of a medicine list. On the right side, I think is a more surgical list. When you looked at our patients who had delirium, 75% who have a reversible cause of delirium, which the initial onset is day 4 or 5, it's infection. All right. Last slide before we come in. You got to know the Beers meds. Has anybody ever heard of the Beers medication list? Yeah. So, and certainly if you were to get sued and you gave a medication, somebody fall, I can tell you it's more for the primary care world, but the lawyers know about this list. So Dr. Beers, it's not about beer like happy hour, it's a doctor. And he made this list that is medications that have an increased chance of having an adverse event in an older adult. So in other words, you give them this medicine, they fall. You give them this medicine, they have delirium. And I think the delirium ones are the most relevant to us. I think the most common one that's prescribed here by our team inappropriately is Benadryl. So Benadryl often gets used as a sleeper. You think, oh, I don't prescribe Benadryl. There's something called the prescribing cascade. And I'll bet you if you looked at your PCA order set, Benadryl is bundled with it, because what happens on the PCA is, right, you get the narcotic, you get Narcan, you get Oxygen. You probably don't realize this, but you get Narcan, you get Oxygen. Benadryl is often bundled there. You have to unbundle it. And then all of a sudden the nurses start using it for reasons you don't know about. That's the most common one. Some of these medicines, Flexeril, I think that gets used. This isn't an orthopedic group, but this does get used in the orthopedic and the spine groups quite a bit. Should be staying away from benzodiazepines. And you can see there's a couple H2 blockers. Probably shouldn't be using any GI prophylaxis for patients on the wards without big stresses. So I just want you to be sensitive as residents to thinking about the medications you're prescribing for your older adults. At the time of discharge, you got to go through that list of those characteristics of the vulnerable older adult. We have to slow down and say, okay, does this patient have delirium? Like if they have some acute cognitive dysfunction, or we got to be managing that as we transition them to a skilled nursing facility, to a nursing home, or even frankly to home if they're going to go home with a low level of delirium. Okay, they have a functional impairment. So you have to actually go over all those characteristics at the time of discharge and have an active management plan for those characteristics. So here we are, we launched this. So this is the American College of Surgeons Geriatric Surgery Verification Program. And we launched it in 2019 and kind of got knocked off the railroad tracks by COVID because, right, we didn't do very well when COVID came along. And I think we can look at this as half full or half empty. We only have 5 verified programs. One of them is on campus. A handful are up in Rochester, and then there's one in Fresno. We just actually certified one a couple weeks ago, and there's 50 that have applied. And so from a glass half full perspective, you can say, well, 50, that's a lot. Okay, here we go. Glass is half empty says there's about 4,500 hospitals in the United States that have inpatient operations. That's kind of a rough number. Gosh, and we really have to penetrate, right? We want to be penetrating 4,000 hospitals. This program was not designed like NSQIP and these other that are really intensive for having to hire SCRs, which is like data collecting people. This was developed that it can go into rural hospitals kind of thing. And I think we're 2 or 3 years in here and with only 50 hospitals. So we'll see. We'll see if this goes or whether we don't go. So the last slide I have here before I ask Dr. Schuler to come back is there's lots of resources out there. If you're interested in geriatric surgery, I put my email down there on the lower right, but right there's some nice publications by the American College of Surgeons. We're done by residents. It's the American College of Surgeons has clinical scholars, so they're done by residents taking their research years. Those are 2 on the right. Nice delirium guideline, and then there's the standards for geriatric surgery. And with that, I'd be happy to take any questions.
Questions or comments? So Dr. Kumler, and then we'll go Dr. McIntyre, Dr. Torpy.
So this is incredibly amazing work, and it makes me proud to see the University of Colorado and our VA leading the nation in how this can be done. One of the tragedies in my mind is that this is happening at our VA and it's not happening at the other hospitals in which we practice. And last week we had a meeting with the executive here at the University of Colorado Hospital. And it struck me that this requires surgical leadership, but a surgeon alone cannot drive this program. It takes all those other disciplines. What do you think was the key in your mind in getting the organizational buy-in to commit the therapy time, the geriatric time, the pharmacy time to making your program successful?
So I think programs start. So first of all, for full disclosure, when I said, was anybody interested in the geriatric surgery grand rounds, Dr. Kumler did raise his hand. So we have somebody who drank the Kool-Aid, so I appreciate you. But I think that there's different models for why hospitals will take on quality programs. As we know, or maybe you don't know, there's a huge selection of quality programs out there right now, almost too many. And it's a question of like, why would you choose one versus another? And I think on campus here, it's the champions at the hospital. And so there is sort of enthusiasm of the folks. And quite frankly, the reason I went over to the VA was to start this program and be one of the leaders in this program because I was developing it nationally. But when you look at, so the Kaiser system in Northern California has 17 hospitals that have all applied to do this. They want to save money, right? So they're about money. Last week, I was at a campus on the East Coast, and they're very interested in the quality aspect, a strong geriatric department. This is the University of Rochester, and they were like, so it's like champions. And so I think there's champions. And I think the third reason that I have not seen yet is a reaction to adverse outcomes, right? So if hospitals have lots of deaths in older adults, right, they're going to react to that and start a program like this. So people that want to save money, strong champions, and a reaction to adverse events, I think would be the 3 buckets of reasons that people kind of join a program like this.
Tom, that was a fantastic presentation. I really appreciate your expertise. So my question is that surgeons tend to be very focused on 30-day outcomes. And I'm going to draw on the trauma experience because I'm sure this is also true of major surgery. So If you're in California, you fall, you have to get admitted for injury. Your in-hospital mortality is 3.5%. Your 1-year mortality is 35%. So have you guys started to look at the effects of this program on 6-month or 12-month outcomes as opposed to 30-day outcomes?
At our VA, we have, like, the data is pretty immature. And so what Dr. McIntyre just got at was, so if somebody has a geriatric syndrome, they fall, right? Who here has fallen in the last 30 or 60 days? Okay, yeah, well, I've fallen because rock climbing with my kids or something. But I used to share an office with Ben Eisman when he was like 92. Ben Eisman would fall 3 or 4 times a month, and we go park him in the intern call room. He'd be lying there. The interns would walk in there. Oh my gosh. But right, that's a geriatric syndrome. The other one that you see a lot afterwards, the residents, is hypoactive delirium. Somebody has purely hypoactive delirium. Their 6-month mortality in our group is 1 in 3. So 1 in 3 are dead. So what you're finding is these fall patients, and the ones that we found was hypoactive delirium. You're finding somebody with a geriatric syndrome. That's somebody who's physiologically vulnerable. They're going to die in 6 months. They've just sort of come with a surgical problem. So we do need to get at that, Robert, and we need to mature those data sets, and we need to take advantage of the programs that are early adopters and start mapping stuff like that. But my bias is we're not going to change the longer term death because that's the underlying vulnerability. This is not a fountain of youth where all of a sudden people are getting younger, right? We're getting them through the hospital, trying to maintain independence and all that. But ultimately, this is the physiologically vulnerable group, and this is not the fountain of youth where we're trying to reverse aging kind of thing. So I'm nervous that at 1 year, as many will be dead. Dr. Torfey.
Yeah, I'll share a paper with you that was just in the Annals of Surgery, where in England they put a program. It didn't have effects on in-hospital, but it did at 1 year.
Oh, I'd like to see that.
So while the microphone's being transferred, reminder, next week and May 22nd, we have visiting professors. So this is not aimed at you in person. This is aimed at the audience online. Please show up. Thank you.
Thanks, Dr. Robinson. That was great. This question is about patient mobility and mobilization, which you alluded to in some of your data. I'm on one of our surgical oncology services now, and half of our patients are over 75. And in the past 5 weeks, there hasn't been a single day where any of them walked more than once or twice a day. And that's not because they don't want to, but it's because they can't. They have bed alarms. If they sit up, all the alarms go off. There's not staff to help them with that. Just tips on mobilizing these patients, because it seems like a huge barrier to getting them better.
So you can see on our daily dashboard, we have tethers. So there's things that you do as a team that prevent the easy mobilization of patients. So tethers would be a patient gets out of the OR, they've got SCDs on their bilateral extremities, a Foley catheter in, a peripheral IV, nasal cannula, whatever, right? They have all this stuff that's just kind of holding. This is somebody who can barely transfer at baseline, kind of hold them down. How a lot of hospital systems handle that is that they actually train like an LPN or MA type of person that will go around and focus on the vulnerable people. This is what like Rochester did last week. So they have an LPN, UAB has an LPN. They train 2 or 3 LPNs that go around. So it's not a high paying. So you don't want to pay a skilled person like a physical therapist, because that wouldn't be a good investment in money. And it's not a good investment in their skill either. But I think it's hiring low-level folks that don't focus on everybody on the surgical ward, but they focus on that 5-10% that are truly at high risk for deconditioning, and you mobilize those people multiple times a day. That would be my answer to that. We're at the time.
From
So
experience, there are a couple of those, and they do a great job.
But as a hospital system, right, you should set up the processes that say, oh, there is this person. They are going to be, you know, the nurses do intake screens. So if they meet a certain threshold on the nurse's intake screen, the early mobility team then goes and sees them. That's how I would strategize. Once you get to be a faculty, you can put that in place.